of disease surveillance response under the disease surveillance and response unit. So today is our World Meningitis Day. And as you know, this is a day set aside for us to improve awareness of meningitis as a condition, as a disease, so that we get to have better outcomes whenever we treat. So today on our webinar, we're going to have some two great gentlemen. One is Dr. Okunga, and number two is Dr. Francis Ngano. Our theme today is to light the road towards defeating meningitis and achieving the World Health Organization goal of defeating meningitis by the year 2030. So without further ado, I'd really like to invite Dr. Okunga to be able to guide us through the first session. Dr. Okunga is a well-known epidemiologist with a lot of years of experience and surveillance, and he also heads the disease surveillance and response unit. So, welcome, Dr. Okunga.
Thank you, Dr. Kadivani, and thank you all colleagues on call. Happy World Meningitis Day. So today I'll quickly try and take you through what we do in terms of disease surveillance at the ministry. As you know, our surveillance function is co-shared between the national government and the ministry and the county government. We are supported by all the other actors, including universities and then professional organizations, and private sector, and all communities at large. So again, the World Meningitis Day is part of our progress towards defeating meningitis by 2030. Next slide. So this will be the outline of my presentation. So largely the background, the rationale for strengthening our bacterial meningitis, and the approaches we are using in surveillance, current challenges, and the way forward. Next slide. So, as you all know, Kenya is part of the African meningitis belt. 5 of our counties lie within the African meningitis belt that stretches from Senegal to Ethiopia. And this belt contains 26 countries with a population of about 500 million people. The overall global plan is for us to eliminate meningitis by 2030. And for us at the ministry, we are strengthening bacterial meningitis in 2 forms. First, enhanced surveillance across the whole country, but also case-based surveillance in the belt counties. Next slide. So these maps just demonstrate the Africa meningitis belt from Senegal right to Ethiopia, as you can see on the slide on the left. And then in Kenya, you can see our counties that lie within the meningitis belt, largely Turkana, West Pokot, Marsabit, Mandera, and bits of Wajir. Next slide. So some of the issues guiding the enhanced surveillance for meningitis, it is clear that the African meningitis belt is expanding. 2, we also have introduced vaccines meningitis in many parts of the continent, and we need to monitor the impact of these vaccines. And we also need to introduce new vaccines in our routine immunization in certain areas. In Kenya, we give meningitis vaccination in very limited areas. Then we also need to monitor the serotypes circulating in Kenya. And also, it's an obligation as part of the elimination goal, global elimination goal. Of course, there are challenges with data quality that we also need to pick out when we sort out during this surveillance work. So largely, the bacterial status changes since the introduction of Afrivac in Africa in 2010, where Neisseria meningitidis A was predominant. So from 2010, we now have more of S. pneumo and then W, C, and X. So in Kenya, we last had a mass immunization campaign in 2021. I think there is a typo there. And it covered Marsabit, Wajir, Mandera, West Pokot, and Turkana, which all lie in the Belt counties. Next slide. And the performance during that campaign, so it was 2019, sorry. So the performance was that. So West Pokot attained high achievement, 97%, but you can also see there were challenges in Marsabit and Wajir. So this will be important. Target age group was 1 year to 29 years. Next slide. So we conduct meningitis in Kenya on the background or in the framework of integrated disease surveillance and response, which is the continental strategy for surveillance and disease response. Bacterial meningitis is one of our priority diseases. We currently monitor 55. And our focus is largely around Neisseria meningitidis, group B strep, Haemophilus influenza type B, and Streptococci pneumoniae. The data is reported weekly, and we enter this into the weekly epidemiological bulletin and also capture it within the Kenya Health Information System. Next slide. So our approach in terms of enhanced surveillance is all counties in the country are expected to report all suspected cases of bacterial meningitis. And we enter this data in forms called MOH 505. And we target that at least 50% of these cases should have CSF samples. Then we have the case-based surveillance, where we are implementing in 7 counties. These are the counties in the meningitis belt. We are adopting a sentinel surveillance approach where we have selected facilities, high volume facilities in these counties. And what we expect here is that for every case, we should have a CSF sample and a case investigation form filled and submitted to the national level. Cultures will be done at selected labs, and we expect that at least 80% of suspected cases should have CSF samples. So the case definitions we use for meningitis, as per our technical guidelines, suspected case is anybody with sudden onset fever, more than 38.5, neck stiffness or other meningeal signs with bulging fontanelle in infants. Probable cases, we now add the aspect of the macroscopic bit of CSF. And we are looking at leukocyte counts above 10 cells per milliliter. And then in infants, besides the CSF leukocyte count, we're also looking at elevated protein or decreased glucose. Then a confirmed case, of course, is where we've confirmed by culture or PCR and identified the particular organisms. Next slide. Then we also have thresholds against which we determine outbreak situations. So we have alert thresholds, which an alert threshold is meant to set systems into high gear to prevent or respond to a potential outbreak. So in counties or populations between 30,000 to 100,000, where we detect 3 suspected cases per week, then we move to alert threshold. Then under 30,000 population, we look at 2 suspected cases in a week. Then epidemic thresholds for population 30 to 100,000, 10 suspected cases per 100,000 inhabitants per week. While under 30,000, 5 suspected cases in 1 week, we consider that to be that area to have crossed the epidemic threshold. Or if we have doubling of the number of cases in a 3-week period. That was the previous thresholds. So when we cross the alert threshold, we expect strengthened surveillance, we expect more lab confirmation, and we expect to prepare for a response. When we cross the epidemic threshold, we expect to conduct mass vaccination, we expect case management teams to be in health facilities with their supplies, and then we'll have response plans put in place and all the other protocols followed. Next. So this is just a pictorial to show us the cases reported this year. As you can see, the highest cases have been reported from Kisumu Central, but the deaths have been in Bureti, Kiminini, and then we also have, so Kiminini is one of those areas. Bureti, Kisumu Central has been high up there. And so we may not restrict ourselves to the belt counties. It is possible that we're also having underreporting, particularly in counties under the belt. So this particular graph may not be quite conclusive. And this is why we need to enhance our surveillance systems in some of these counties. Next slide. So the challenges we're experiencing in our meningitis surveillance currently, many of the suspected cases are not being tested. Samples are not being taken for laboratory confirmation. A lot of the treatment is presumptive. Next, we also have challenges around the investments counties are putting into primary healthcare. We also have issues around the knowledge and skills of healthcare workers. There are data gaps We also have a high turnover of surveillance staff in the counties, and also inadequate involvement of clinicians in surveillance. Lab capacity has been a challenge in many of the counties, but part of the work we are doing now in terms of enhancing our meningitis surveillance is building capacity for the labs, peripheral laboratories to conduct cultures and other necessary tests, and also strengthening the referral system for samples for the counties to be able to refer certain samples to the national reference labs. So in terms of country priorities, the issues are really around strengthening advocacy and awareness for meningitis, improving data from facilities, strengthening diagnosis at county level, introduction of meningitis into the routine immunization, and the KENITAG will give us guidance on this in due course. Similarly, we're also looking at enhancing community surveillance for bacterial meningitis, and then surveillance for the sequelae. We are expected to provide that feedback at WHA in 2025. So way forward, I think basically this is what we've said: follow up, increased surveillance, building capacity of clinicians and the surveillance teams, strengthening our referral mechanisms, and strengthening the actual collection of samples by lumbar puncture, and also having reagents at the counties for culture, and also PCR at national level. So thank you very much, Asante.
Yeah, thank you very much, Dr. Okunga. I'll urge us to note our questions. We shall have a Q&A session just after the next presentation. So note them down, and also put them on the Q&A, the chat, so that we can handle them at the end of the session. Allow me to now introduce a great pediatrician who works with us currently at the Division of Disease Surveillance and Response, and the Disease Surveillance and Response Unit. Let's put on together for Dr. Francis Ndala. Karibu.
Asante.
Hannah, I don't know whether you have lost you from my network part. Dr. Nanga?
Yes, Dr. Kadivani, can you be here?
Go ahead.
Can you be able to hear me clearly?
Yeah, I can hear you now.
Okay, thank you very much. And once again, thank you very much for that kind introduction. I'll take us through case management of bacterial meningitis with a little bit focus on Neisseria meningitis. Next slide. So the outline of my presentation, I'll give us the objectives, definition of meningitis and its causes, the clinical presentation, laboratory investigations, treatments, and its prevention. So next slide. For the specific objectives is basically to discuss meningitis surveillance with a focus on case detection, reporting, and investigation. Then I'll describe meningitis sample collection, transportation, and laboratory testing. Then I'll summarize the current Neisseria meningitis case management protocol. So for the definition, really, meningitis is the inflammation of the meningeal layers that covers the brain, the spinal cord, the brain and the spinal cord, which can be caused by an infectious or an infectious agent. So the three meningeal layers are the dura mater, the arachnoid layer, and then the pia mater. Next slide. So there are 4 types of infectious agents that really cause meningitis. The first one is bacterial, which the main culprit is strep pneumonia, causing about 50% of all bacterial meningitis. This is followed by Neisseria meningitis, then group B streptococci, Listeria monocytogenes, and then Haemophilus influenza type B, which causes less than 10% of bacterial meningitis. Then we have viral causes, which include herpes simplex virus, cytomegalovirus, then the HIV virus, then parasitic, for example, malaria, toxoplasmosis, then fungal could be cryptococcal or candida. So I'll show, this is just a list showing some of the most common causes of bacterial meningitis by age and risk factors. So for children less than 3 months, most of them are affected by group B streptococci, E. coli, or Listeria monocytogenes. Then for those who are aged more than 3 months, the main culprit is strep pneumo, Neisseria meningitis, then HIV, that is Haemophilus influenza B virus. Then for pregnant women, Listeria monocytogenes is also a common cause. Then for adults aged more than 50 years, strep pneumo, Neisseria meningitis, then gram-negative bacilli comes in. Then there are cases of group B streptococcus, then Staph aureus. Then for those who are immunosuppressed, also the same culprits apply, led by strep pneumo and Neisseria meningitis. Then for those who are post-traumatic or post-neurosurgery, Staph epidermidis, Staph aureus, and Pseudomonas aeruginosa are main culprits. So I'll go to the clinical presentation, and really is what my colleague, Dr. Okunga, had just said. That is any person with weakness and other meningeal signs and symptoms, including vomiting, headache, drowsiness, a positive Koenig's sign, Brudzinski's side, and sometimes you might have a bulging fontanelle in infants. Next. So probable, I think I will not really go into much of this because Dr. Okunga had presented on the same. Next slide. Then just list something little on the confirmed cases. This is any suspected case with probable, any suspected or probable case that is laboratory confirmed by culture or identifying the cause, usually through PCR. Next. So these are some of the laboratory investigations. So we should not limit ourselves to just the CSF analysis, but for the same patient could have differential diagnosis. And that is why it's important for us to also go ahead and do a complete blood count, acute phase proteins, random blood sugar, blood slides. Then you might also do CT or MRIs and any other investigations that might be indicated. So I'll just give a brief description on how we collect CSF specimen. I know this happens in our facilities, but just to be suspected, according to the standard case definition, CSF is the best clinical specimen to collection. Lumbar puncture is usually an invasive procedure that is performed by trained personnel under aseptic conditions. The procedure usually takes about 30 minutes. Next slide, please. So you require sterile gloves, you require a surgical mask, sterile gauze, adhesive bandage. Then you require lumbar puncture needles, different sizes for adults and for children. So you also require 3 sterile screw cap and cryogenic tubes. You need syringes and needles. You need a transport container, then a puncture-resistant container, then a transport medium. If you cannot be able to analyze this CSF immediately, then the collection tubes should be correctly labeled. So you need to strengthen your skin, then observe strict aseptic techniques. You should wash your hands, or have a surgical mask and sterile gloves. Then after every other patient, you should change your gloves. So be sure that your unique patient identification number matches that on the request forms and also the collection tube. Ensure that the patient is motionless during the procedure. Maybe the patient may be sitting or lying down. Then you disinfect the skin and then allow the skin to completely dry. Next slide. So this is just a pictorial, a picture showing how we should position the patient as we are collecting our CSF. For adults, usually we go for the space that is between L4 and L5, and introduce the needle, the LP needles into the skin with the bevel facing up. Next slide, Dr. So accurate placement is usually determined by a flow of CSF, which is normally clear and colorless. You should collect about 5 ml into 3 to 4 separate sterile screw cap tubes, then ensure that the tubes are tightly closed. So you should deliver the CSF to the laboratory as soon as possible. And really, this is how you collect the CSF into the tubes. Tube 1, you want to do your chemistry. That is protein and you want to do your protein and glucose. Tube 2, microbiology, bacterial or fungal. Tube 3, AFB and other specialist tests, including the PCR. Then tube 4, hematology for your cell count. Then this is just a comparison of CSF findings in different forms of meningitis, and I'll just go quickly through it briefly. And for the normal CSF, it's usually colorless with a pressure of less than 180 millimeters of water. The WBC count is usually 0 to 5. They are usually non-neutrophils, and glucose is usually 60%, greater than 60% of the blood glucose, with proteins being 15 to 50. Then for the acute bacterial cases of meningitis, the appearance is usually turbid. Pressure is usually increased with a WBC count of between 100 and 50,000. Usually the counts are of neutrophils. The glucose levels are usually quite low, usually less than 40% of the blood glucose. Proteins are usually increased, and the gram stain might turn out to be positive in more than 60% of the cases. PCR is usually positive. And for the viral meningitis, the appearance is usually clear or opalescent. The pressure may be normal or increased. The white blood cell count is usually 5 to 500, and neutrophils are usually less than 50%. The glucose may be normal. The proteins may also be normal or slightly increased. Cultures may be positive, but is usually quite low at less than 50%. The PCR may be positive. For TB meningitis, the CSF may be clear or opalescent with increased pressures. The WBC count is usually 5 to 500. Neutrophils are usually less than 50%. Then the glucose is usually low with increased proteins. AFB is usually positive, but in less than 90% of the cases. And culture is usually positive in 50 to 80% of the cases. Then for the fungal meningitis, the appearance is usually clear with a normal or increased pressure. The white blood cell count is usually between 20 to 500 with a neutrophil count of less than 50%. the glucose is usually low, but proteins may be increased. Then gram stain is usually positive. You might be able to culture such fungal meningitis in 25 to 50% of the cases, and you can also use Indian ink stain. Next slide, Daktari. So once you are through, you draw your needle and cover the insertion site with an adhesive bandage. You discard the needle in a puncture-resistant sharp container. Then you instruct the patient to lie down 30 to 60 minutes after the procedure. You remove your masks and gloves, discard in the appropriate containers, and as you do this, once you are through, you perform hand hygiene with soap and water after removing the PPEs. So you should transport the CSF immediately or within 1 hour. Should be transported in triple package at ambient temperatures as fast as possible. So a little bit, I'll focus a little bit on the Neisseria meningitis, since it's the one that's really prone to epidemics, and really the Neisseria meningitis is a fastidious encapsulated gram-negative aerobic gram-negative diplococci with a 10 to 15% mortality rate, and it usually spreads through respiratory droplet inoculation. It can also spread via direct contact. It has an incubation period of 2 to 10 days on average, but with an average of 4 days. You can have a carrier state in 8 to 25% of the human population who are infected from several days to several months, and there are 13 Neisseria meningitis serogroups, but 6 are known to cause life-threatening disease, and that is A, B, C, W, 135, Y, and X. And previously, Neisseria meningitis A was the one that was really associated with much of the outbreaks, but currently Neisseria meningitis C, W, and X is associated with increased outbreaks. So it usually colonizes the mucosal surfaces from where it is able to invade the body, including the CNS. So treatment, just a bit on the treatment. So these patients should be treated as quick as possible using the appropriate antibiotics, and where possible, the LP should always precede this antibiotic treatment. And once you have done your LP, you start your presumptive treatment without having to wait for the laboratory results. So recommended treatment for meningococcal meningitis, kindly note this is during epidemics. In children aged 0 to 2 months, we usually give ceftriaxone at 100 milligrams per kg per day. Can be given IM or IV once a day for 7 days. Then in children who are older than 2 months, you also give the same dose of ceftriaxone, IM or IV for 5 days. In children over 14 years and in adults, you give ceftriaxone 2 grams per day once daily, IM or IV for 5 days. And I just repeat that is during epidemics, where we expect really high numbers of these patients with meningitis. So patients admitted to health centers who are not improving should be transferred immediately to higher facilities. Outside epidemics, the recommended treatments for meningitis and in children and in adults is usually 7 to 14 days. And where we suspect pneumococcal meningitis or where pneumococcal meningitis has been confirmed during or outside outbreaks, you should extend the duration of treatment for up to 14 days. Next slide. So prophylaxis of family members of a case is not advised. Not advised during epidemics for logistical and uncertainty, as well as to if there are any additional benefits. But when we are outside epidemics and we have such cases of meningococcal meningitis, you can give chemoprophylaxis. You can either use ciprofloxacin or ceftriaxone. If you are using ciprofloxacin, usually a single dose of 500 milligrams is given for adults or adolescents. For children, you give 15 milligrams per kg orally for those who are aged less than 12 hours. So 12 years, sorry. Rifampicin is not recommended, especially in our meningitic belt, because of the risk of antibiotic resistance. So prophylaxis should be administered as soon as possible so as to reduce the risk of new cases in the household. Next, please. So this is just how we go about deciding on the vaccinations that on the vaccine that should be introduced during an epidemic. And if such cases are confirmed and your serotype, your main serotype is MEN-A, that is Neisseria meningitis serogroup A. If it's the main culprit and less than 30% of such cases are not either C or W, you go ahead and give your MEN-A conjugate vaccine. But if the main culprit is MEN-A, but more than 30% of these cases have also C or W, the serogroups, that is, you go ahead and give ACW containing vaccine. That is the vaccines with those targeted against those serogroups. Then also the second part, where if the main pathogen is either MEN-C or W, and the epidemics thresholds are crossed, you give ACW containing vaccines. And there is always an option of just giving a monovalent C conjugate vaccine. Then if the main culprit is MEN-X or Haemophilus influenza B or strep pneumo, you just go ahead and do your usual case management. There is usually no vaccination recommended at this time, but plans and research is underway to see whether we can be able to introduce the MEN-X vaccine. So in our country, I just want to mention that we usually have the quadrivalent vaccine available in most of our private facilities, but unfortunately, we have not been able to introduce the same in our public facilities. So follow-up for survivors is quite necessary, so that since we recognize that 10 to 20% of these patients develop sequelae, including brain damage, hearing loss, learning disabilities, and blindness, data should be collected and collated of all survivors with such sequelae. And as a country, plans are underway, and really this should be established so that we establish a surveillance system of sequelae, a referral mechanism, how we can be able to follow up such cases in our communities, and not only following up, but we should be able to support such survivors. And at the end of the day, the community, the entire community should be engaged. And really, we cannot be able to achieve much if we don't have any political commitment. So we need to really advocate and have more resources towards this follow-up of such sequelae. Then there should be established public health and social policies so that to enable these patients the patients with such sequelae lead a fruitful life. I want to thank everyone for listening, and I hand over back to the moderator, Dr. Kadivani.
Yeah, thank you very much, Dr. Hannah. And as I promised you can see how he has delivered, as well as Dr. Kunga. Thank you once more, Kunga and Dr. Nanga. For now, we shall go into Q&A session. So I'd just like to know if anyone wants to ask a question, or go direct to the Q&A questions on the board. Okay. There's Angela Kezengwa. She's saying, I'm looking for meningitis survivors and someone who lost sight due to meningitis. Any contacts I will appreciate. Okay. That one is looking for some meningitis survivors. I don't know where they go, whether Nana, you have any leads in terms of this, or Dr. Kunga, or Dr. Even Carol.
I will ask Carol to contribute to it, but currently we don't have an established such survivor surveillance system in the country. But I know plans are really underway to have one established. But probably Carol can add to that.
Thank you. Carol?
No, I also don't have information, but I have picked her email address, and I will get in touch with the member from Confederation of Meningitis Organization in the country. And if there are cases, then we can be able to link up the two. Angela, thank you.
I can see Anne-Marie, you have raised your hand. Is it on the same matter?
Good afternoon, everybody, and thank you to Dr. Okunga and Dr. Nganga for an excellent presentation. Mine is a comment. I think you brought it out in your presentation that often we just give empiric treatment based on clinical signs, or rather presumptive treatment based on the clinical signs, and very rarely are clinicians collecting CSF. So I'd just like to encourage my colleagues that we get into the habit of collecting CSFs. As part of a program where we were supporting microbiome capacity in various counties, we found that Machakos County is doing a very good job in CSF collection. But many other places, including Kenyatta, where I work, we don't really have many samples. So I'm a pediatrician, and I'd want to encourage clinicians, please take those CSF samples. There are very few contraindications for you failing to do a lumbar puncture. And what is happening is when you don't make the diagnosis, then you don't treat the child for an adequate period of time. And my colleagues who are sitting in the neuro clinic will tell you, we have a lot of children with neurodevelopmental delay. And when you scan them, what you find is just global atrophy. And somewhere in the history, this child had fever and convulsions. Yeah. So please, can we investigate children as well as adults properly, make correct diagnosis, and give adequate treatment? Thank you so much.
Thank you very much. Like now to move. There's a question from Joseph Muturi. I think Muturi is asking about the CPD points. Secretariat will get back to you, Joseph. There is an anonymous attendee, and the question is the data limited only to bacterial meningitis? Is TBM and crypto taken care of? Maybe Carol and Nana respond to that. Is the data only limited to bacterial meningitis, or is TB meningitis and crypto taken care of? Maybe.
So, okay, it's not limited. It's just that today the focus was a little bit more on the epidemic causing meningitis, but we are not limiting ourselves.
Yeah, thank you. Carol?
But just in addition, for surveillance, our bacterial meningitis is a priority disease, as Dr. Okunga had mentioned. In fact, for a long time, we have been reporting meningococcal meningitis only. Only last year, when we rolled out the third edition of the Integrated Disease Surveillance Strategy, is when we started focusing on bacterial meningitis with a focus on the four bacteria that Dr. Okunga mentioned. So Strep pneumo, Group B, Hib, and Neisseria meningitidis. Thank you, and over.
Yeah, thank you. Thank you very much. From our division as a surveillance, we are mainly interested in getting to identify outbreaks of epidemics as early as possible. So we concentrate more on the type of diseases that are epidemic prone. In this case, it's bacterial meningitis. Okay, thank you. James Wambugu, kindly How can I get the slides? Secretariat will get back to you. So, Carol, do you want to respond to that?
I think anyone who's interested in the slides can post their email address. I'm picking them. Then we will be able to share. Thank you.
Thank you. Joy Yaya is also interested in the notes. May I kindly get the notes on email? The email is provided
Apologies
there.
for the interruption, Tim.
Yes, go ahead.
With regards to the slides, we'll pull the whole attendee list from our Zoom, and we can share from there. So there won't be a reason for people to post the emails again.
Thank you very much, also.
Okay.
So, anonymous attendee, what are the current serotypes affecting the meningococcal belts? I think that was covered what Dr. Kunga presented as well as Dr. Nana, but you'd like to go, Dr. Nana? Or Carol? The current serotypes affecting the meningococcal belt?
Dr. So I said there are 13 serogroups that cause, there are 13 serogroups of Neisseria, but 6 are the ones that cause 6 are the ones that cause life-threatening diseases, including A, B, C, W, Y, X. So currently, around the meningitic belt, since the introduction of Neisseria meningitis vaccine A against type A, there have been a market reduction, and in fact, over the past about 5 years, we have not had any outbreaks of Neisseria meningitis A. The current outbreak that is happening in the western part of Africa, mostly Niger, it's usually it's been caused by Neisseria meningitis serogroup C. That is the one that is currently causing the current epidemic that is happening.
Thank you very much, Dr. Ganga. Jesse Watampora, thank you for the informative presentation. Thank you very much, Jesse. Franklin Mutwiri said, I got a patient with blindness caused to meningitis. So I think there's somebody who's interested in meningitis survivors. I think we can link up with Frank to give you those details as well. Thank you. Anonymous attendee, are there cases of multi-drug resistant meningitis and how to go about it? Dr. Nanga, can you address that? Are the cases of multi-drug resistance meningitis and how to go about it?
So for Neisseria meningitis, cases of resistance are quite low. So they are quite low. So our ceftriaxone is really the drug of choice. But where there is resistance, the drug patterns is usually guided by the MCS that you might have performed on the CSF. Okay. So the sensitivity tests are the ones that will guide on the kind of treatment that you go ahead and treat.
Okay, so that is case by case, and then culture and sensitivity guide as well. Angela Kezengwa say thank you so much. I am working on awareness story for publication. I really appreciate it. Thank you. Jesse, do you have any documented cases of AMR, the recent meningitis cases? And if we do, which antibiotics are affected? Dr. Nana, would like to go for this as well? Any cases of AMR, the recent meningitis cases, and what antibiotics have been affected? So the same goes to the culture sensitivity we're talking about. Are there any known AMR cases that have been reported? Ganga?
So far from Neisseria meningitis, we have not been able to collect such cases. And as you said, it's individual based. So we don't have any data that that is showing any AMR resistance at the moment. But okay. I don't know whether my colleagues from KNH can add that.
Yeah, if anyone can be able to answer that. Okay. Anonymous attendee is asking, how do we manage viral and fungal meningitis? I think those are clearly for specific case management when you get the viral or the fungal meningitis. Nana, do you like to respond to that?
Not really. I just want, just as you have rightly said, it's individualized. So for the particular virus or fungal or any other bacteria, apart from the one that I've presented, you go ahead and just manage appropriately.
Okay, thank you. Anonymous attendee is also asking, is it worthy to do a lumbar puncture after starting empiric treatment? Anga, you can handle that. Is it worth it to do an LP after you started the empiric treatment?
Yes, I just want to emphasize that we should always do our LPs, regardless whether we have started our antibiotic treatment or not, because this is what will guide us in case such patients don't recover appropriately. And also, it will also help us with the kind of surveillance or the kind of data that we want to generate, so that we can be able to go to come up with clear line policies on how we manage our cases. So clearly, an LP is indicated in all suspected meningitis cases.
Okay, yeah, thank you.
I can make a comment on that as
please
well.
Go ahead,
Sorry. Yes, I was going to say, once you commence your antibiotic, that CSF will be sterile within 2 hours if it is strep pneumo, and maybe 8 to 12 hours if you're talking about Neisseria. So that's why we insist that you take a lumbar puncture sample, you take a CSF sample before you commence the antibiotics. The only thing that may be of value once you have already commenced the antibiotics is if the cell count is still a bit high or the proteins are elevated. But you see, at that point, it's like you're trying to infer. You will not be able to isolate any organism at that point. So the earlier you do the LP, the better. Thank you.
Thank you, Dr. Terry. But also take note of the other forms of meningitis other than bacterial causes. We also have the viral causes. We also have TB and also the fungal sources. So it is still worthwhile to do an LP in the event that there is non-bacterial meningitis.
Absolutely. And the table that Dr. Nganga presented is very useful for you to look at the cell counts, the protein levels, to try and interpret what could be happening. And in private hospitals, we also have a CSF biofile that is able to identify some of those not yet in the public sector. Thanks.
Thank you very much, Dr. Terry. Samuel Ramko is asking, in children with cerebral palsy who present with convulsions and fever, and you're unable to do CSF analysis, since clinical signs are hard to elicit in such patients, how do we approach such patients? Dr. Nganga? You have any response to that in cerebral palsy? And it's difficult to elicit the signs. How do you go about such patients who you suspect have meningitis?
So I think for our case definition, we just have to follow our case definition and neck stiffness and any other meningeal sign. So if you just follow that criteria, you'll be able to determine which patient is meningitis and which patient is through cerebral palsy. And you know, these cerebral palsy patients, they usually have a prior history of something having happened during delivery or in the ANC. So really, if we follow the clinical criteria that we presented, we'll be able to determine the kind of approach to take in such patients.
Thank you. Samuel Ocheng is asking, I noticed your links appear on email at 10 or 15 minutes late. What's not happening? I think Secretariat will get back to you on that. Wambugu, they provided the email address. Then Isaac Kengwe is asking, is ceftriaxone at 100 milligrams per kg given? I am recommended or safe? Is the safety of giving 100 milligrams per kg of ceftriaxone intramuscularly? Is it safe? You want to tackle that, Nganga?
So the intravenous method or mode of treatment is the one that is is recommended. But here, remember I was talking about in epidemics. Sometimes you might have overwhelming numbers, which might overrun a system, a healthcare system. So that is where the IM aspect comes in. And you remember, you also have IM preparation of the ceftriaxone, which can be used. But ideally, intravenous treatment is the one that should be used. Just that I was really talking more of epidemics rather than when we are not having epidemics.
Okay, yeah, thank you. And it's also recommended if the dose is high, you can split it to give into one side and the other side the remaining bit. But I know with the ceftriaxone, you can have quite a painful side, even when give it IV. Okay. Anonymous attendee. In the case management, you only mentioned antibiotic regimen for bacterial meningitis. How about management of other causes of meningitis? I think this has been handled. There was a question similar to that earlier. Gati Makongo, after taking CSF for analysis, does the lab investigations cater for broader causative agents?
Yes, the labs are not limited to as to what the labs are usually guided by us clinicians on the kind of investigations that we want. So it's our role to ensure that whatever we might be suspecting is clearly captured in our request form so that the lab can act on it. And really remember to provide a brief clinical history on the lab request forms.
Thank you. There is Joseph Wamugo. He says, I saw on the slide 7-day treatment, while you currently treat for minimum 14 days. Could you please clarify from the slide? Maybe you can clarify about epidemics, during epidemics and the conventional treatment.
So really, I just want to re-emphasize that the presentation I made was basically towards the epidemic-prone bacterial meningitis, and it's Neisseria meningitis in particular. But the treatment protocols outside epidemics remain as guided by the various treatment protocols that are available. So I just want us to just be clear on that.
Thank you. There is an anonymous attendee. Where does a baseline TB LAM test apply? Because in HIV guidelines, if a patient is newly diagnosed and has advanced HIV disease, urine sample for TB LAM is conducted. Is there any relevance of these tests, or is it phased out? If you can handle that, Dr. Lang. Talking about TB LAM tests and whether it is useful.
So the LAM test is recommended for those patients who are immunosuppressed. So in case you have such a case, you are not limited. You can always ask for that test. But if you are not immunosuppressed, there is actually no indication for it. And I would also want to, and Dr. Anne-Marie to add on to that.
Okay. Is Anne on the call still? Okay, we can go to the
Hello,
next question.
yes.
Yes, go ahead, Dr.
Can you hear me?
Doc, your network is a bit, your connection is a bit patchy. Have we lost you, Dr.
I lost you for a moment. Was there a question?
Yeah,
Hello?
the question was about the usefulness
Yes,
of,
sorry, can you hear me now?
yes, I can hear you now. The
I
question
think
was
so.
about,
Maybe type and then I can respond.
okay. The question was this, Dr. that what is the usefulness of the EVLAM test?
Oh, okay. A TB lamb, a urine lamb, is useful in patients who are immunosuppressed. That is the category of patients in which utility has been proven. So primarily HIV-infected patients with a CD4 count of less than 200 and more so a CD4 count of less than 50. So it is just one of the many tests you can do to see if this patient has active tuberculosis. So for TB meningitis, you're still going to rely very heavily on your clinical signs, doing the lumbar puncture, looking at the CSF, and maybe imaging to see if there's any tuberculomas or enhancement of the meninges, or in children, a new onset of hydrocephalus. So LAM is just one of the additional tests. And in fact, if you do it in a patient who is not immunosuppressed, you may actually get a false positive. So you need to put all the tests together before you can make a diagnosis.
Thank you. Thank you. Then there is anonymous attendee. Asks a client who presents with fever and convulsions. Once you take CSF, can you begin meningitis treatment as you wait for the confirmation results? And the answer is yes. You start empirical treatment immediately. You take the CSF. Catherine Kifusi. Just a moment. Nelson, please allow me to give the next question. Or there's another question after that? Okay. Yeah, thank you very much. I'd now like to hand over to Nelson, and wish to thank all of you, particularly the two presenters who have done an excellent job. And back to you, Nelson. Thank you.
All right, thank you, Dr. Kavidane and team for the excellent presentation. I think we have gained a lot from the talk today. Mine is just to appreciate the rest of the attendees for joining us today, and also to inform you that all CPD's queries raised on this platform for this session will be replied via email. So kindly wait, and we'll reply all your queries, and if you have an issue, we'll be able to follow up and sort you. Thank you once again. Do have a wonderful afternoon.